Yeah, so I
Nada.
have a lot of questions myself, but I think we're going to go to I mean, like you said, there was great lectures. So we have a few questions. The first one I think is actually for Dr. Sophocleos. I'm not sure he is coming back, but one of the questions, and maybe one of you all can answer this also, is there any concern on radiation dose to the operator during oh, there's Kosti.
Okay, it's
So,
coming.
so Kosti, the question I guess is for you and PET CT ablation.
Yeah.
So, is there any concern on radiation dose to the operator during ablation when using the split dose technique with PET CT?
Good
Was the
question.
RFA or ablation performed using the PET CT under CT guidance?
The, so the question about radiation, let's start with that. So we did
Yeah.
actually a study before we did that split dose technique, which I didn't mention, that actually we calculated the dose to the operator, and we found out that it does not exceed any radiation that the operator would get with any fluoroscopically guided procedure, CT fluoroscopy or something like that. So it's a very low level of radiation exposure to staff. Having said that, you don't need to stay in the room while we're acquiring the imaging. The only radiation exposure is when we actually introduce the needle and we do CT fluoroscopy with the needle in place to actually see what's happening. So there's very little added radiation from the PET source anyway, if that's the question. The second question was if that was done with CT. Yes, of course. It is a PET CT, and the machine is modified somehow for intervention, so the gantry is a little bit bigger than the usual. But other than that, yes, it's a regular PET CT that can be also used for diagnostic study. Actually, we are going to be having a lot of research done on that machine this year, but I'm not going to tell you exactly what because it's very exciting and confidential for the moment. But hopefully I'll have some news in a year that will be done with biopsies again, PET guided after local regional therapy, but I'm not going to say much more. I'll keep the suspense on. I got to run. I have another patient here waiting, but it was good that this question came in between. Anything on this before I move on?
So my question about you showed us how to before do the ablation, how to do the margin of the lesion. So you use a 3D measurement of the margin. So that before ablation or you did it. How about post ablation? Also use the 3D to measurement about your effect of the ablation, the result. Do you use that to do the post before and post both, or just before?
So you're asking me when we're doing the 3D.
The 3D measurement.
The 3D has to be done after anyway. That's mandatory. If you want to do it before to see the tumor, of course you do that either before or after, but you have to do both to count the margin. So when you're doing 3D, you have to segment the tumor in 3D and the ablation zone in 3D and make sure that this is done in a very comparable position. So in our case, it's relatively easy because we're using not an imported old scan, but we're using the scans of the same day. So accuracy is much higher. Having said that, other places in Europe that they don't use CT, they use imported images and they do manual corrections. And it's a lot of discussion about, those corrections in elastic versus rigid registrations. I do think that when it comes to ablation, we need to mandate that even if you're doing the procedure with ultrasound, you need to get a CT after within 24 hours to actually see the ablation zone, because I think otherwise the errors that we're introducing may exceed the small margin. So, if you really want to do a 5 millimeter margin, all these 3D measurements don't have given us so far what is their margin of error is. So if their margin of error, for example, is 2 millimeters, a 3 millimeter measurement can be 5, and a 5 millimeter measurement could be 7 or 3. So I think it's important to minimize that. So although it's feasible to do elastic corrections, I think these introduce another error that makes these small measurements more inaccurate than we could if we mandate a rigid registration on the post-ablation scans, at least. That's my opinion, and I hope it's going to be reflected on guidelines that I know Nauman and Martin and all that are trying to update through the SIO.
Thanks. So if anyone that's interested, there is a great paper on this from Memorial Sloan Kettering that I believe now was published in Radiology about 4 or 5 years ago, maybe even longer, that describes it. Now, of course, one would need, if they're interested, to have a PET-CT interventional suite, and not really clear how many institutions have that type of technology available. But at Sloan Kettering, it seems that they do. So there's another question.
David, let me just say something here. I want to make clear to all of you that you don't need a dedicated PET-CT. You can use any of your PET-CTs in nuclear medicine as long as you make certain modifications to use that room for intervention and with anesthesia in the room. So the only thing you need is a strong chairman and a strong IR section to say, you know, every 2 weeks, every other Wednesday or whatever, if you have more cases every Thursday, 1 day a week, we're going to use this for intervention and make it as such. You don't need to have it as we are lucky to, and at this point we have 2. We have dedicated PETs in IR, but in reality, any PET could be used as such if you make the certain modifications. You don't need to have an extra machine just for that. Just to make that clear.
That's definitely a great point that you make. I mean, obviously, if you're able to use that a PET-CT that's in another area, then that would be helpful. Right. But I was just kind of just trying to bring up to the listeners that you know, it's not common that a group has their own, and you guys have now 2.
Yes.
So you know, I think it's great to have. Believe me.
Sure. But I'm just saying, if you wanted to do it at Yale, what you need to do is a good deal with your nuclear medicine people. That's all you need to do, really. Yeah. Buy them coffee every morning. All right. Gotta go. See you later, guys.
Have a good day.
Thank you, Coffee. Thank you very much.
Thank you.
So there's another question that well, I actually have a few more questions at least, and then like I said, I have some of my own. But I believe this one's probably to Dr. Liu, which has to do with what factors do you evaluate when a patient has, you know, portal vein tumor thrombus to decide if they are candidates for CERT versus systemic therapy alone?
David.
The presence of portal vein thrombus is an area where patients do very poorly because of rapid progression of disease. And because of, and although it's a very common clinical presentation, we have very little evidence as to what works best in these patients. If you look at some guidance, especially if you look at Asia and in China, surgical resection is part of the conversation of the management of portal vein tumor thrombus. If you look at some of the guidance, for instance, from Japan, SBRT, or external beam radiation, is the first line. And of course, if you look at some of the published literature of systemic therapy also offers some benefit. So in our multidisciplinary board, these areas are very hotly debated. So that was one of the reasons why we tried to look at our survival data using radiation lobectomy techniques. Essentially, at this point in time, within our clinic, within our multidisciplinary group, we actually see SIRT as a first-line therapy. But as many people that are familiar with SIRT therapy know, there are certain limits of what you can and can't do based on your mapping procedure and calculation of radiation. Particularly one which is referred to as the pulmonary shunt fraction, or leakage of radiation that could occur as a result of the radiation going from the tumor into the lungs. Specifically in those cases where patients have leakage or pulmonary shunt that doesn't allow for proper treatment with SIRT, with radiation lobectomy, as well as those patients with main portal vein thrombus, thrombus, we actually give them a series of systemic therapy. If you look at lenvatinib, which is a multi-kinase inhibitor, the radiographic response rates of lenvatinib based on their major trial called REFLECT are of around 72%. So much like per Professor Goldberg's comments, we use these combination therapies to consolidate the treatment. So rather than just looking at SIRT alone, we look as a group to see whether these patients may actually benefit from systemic therapy. Our data for segmental and branch portal vein occlusion is much better than external beam radiation therapy. And certainly in North America, because we have such a high surgical population, we generally don't, at least in our institution, we generally don't operate on PVTT patients unless they've demonstrated stability and response for at least 2 years. So that's how we incorporate our SIRT into PVTT. But as I mentioned, I think that there's still a lot of controversy, and it's based on local expertise as well as opinion.
Yeah, thanks.
Okay.
Yeah, so can I just ask a follow-up?
I'm afraid about Dr. Liu. I'm sorry?
Yes.
Yeah.
Okay,
I'm afraid about how to prevent liver cirrhosis post radio embolization. You use the yttrium-90 embolization.
It's a very good question, and I think hopefully during the talk I'd outlined that there are a number of different techniques of radioembolization that we can use, because we can intensify therapy not only to treat the tumor but also to treat the liver. We have to be very careful about how much radiation we give. The prevention of cirrhosis is obviously a major concern, and when we perform lobectomy or segmentectomy treatments, we think of this as equivalent to surgical resection. So we worked very closely with our liver surgeons to ensure that if they were to surgically resect that patient, that they would still survive based on hepatic reserve. Because we know, to your point, that at a certain level, that the liver that's been exposed to the radiation will undergo cirrhotic changes, fibrosis, and potential portal hypertension. So we have a tendency to use less whole liver treatment, except for in extraordinary circumstances. And we are much more precise and selective in the way that we give the radiation, so that the area we treat will probably transform into cirrhotic change or potentially even shrink down, but the remainder of the liver that is not exposed to the radiation will still remain, and hopefully that reserve will help preserve liver function.
Thank you so much.
So can I just ask one quick thing here about just the mechanism? Because there's a lot of publications coming out of Asia that they do conventional TACE for portal vein tumor thrombus. And some is quite extensive. And you do see, because the lapidol obviously is liquid, that it does insinuate and it does percolate through the sinusoids, gets into the portal vein and stays there. But because the SIRT is particulate, where exactly does it end up such that it causes the portal vein tumor thrombus to shrink? And I understand the situation you're saying with the survival rates, but in terms of the actual response rates, and how it retracts, why does lapidol getting in there not work as well as you think as compared to SIRT, given its particular properties?
Sure. I think for the first question we have to ask is, what is conventional TACE? So let's first set our expectations. So conventional TACE, I think in the majority of practices in Asia, consists of a lapidol-based admixture of either epirubicin, doxorubicin, or potentially cisplatin, and potentially followed up with either a cisplatin infusion or gel foam in the end. So I think we're using different chemotherapeutics and slightly different techniques. However, to your point about the deposition of lapidol, lapidol's mechanism in these situations is still going to be predominantly driven by necrosis and ischemia. And of course, we're aware of the risks of the tumor potentially becoming too necrotic too soon, causing not only necrosis, but also tissue breakdown, and thus the potential for metastatic presentation or spread of the tumor itself. There's also a very well-described narrative with respect to embolization causing upregulation of angiogenesis. So in other words, the tumor becomes more aggressive because of the hypoxia. And of course, with tumor vein PVTT, that is potentially the case. So you could upregulate the tumor. To your point, Professor Madoff, when we take a look at the post-implantation SIRT therapy using either PET-CT or nuclear medicine Bremsstrahlung scan, we see the radioactivity within the tumor itself. So the radioactivity is getting into the tumor. And if we perform contrast-enhanced CT immediately after the implantation, we still see vascularization of the tumor. So we know from those two points, as well as from the histopathology, that this is not embolic in nature. Now, the reason why that's potentially advantageous is because the damage that causes the tumor to shrink in SIRT therapy is beta particle emission, which actually causes the DNA to break down, which leads to programmed cell death, which is known as apoptosis. So the tumoricidal effects are slower, less aggressive than embolization, do not result in the same type of angiogenesis or upregulation of the tumor, and allow the tumor to contract rather than break off. And I believe that those are very clear rationales for the use of SIRT therapy in a more precise manner than other radiation sources, such as SABR or SBRT.
Got it. Thank you. So I guess we have time maybe for one last question, and we want to get the other people involved. And Renji, I don't know if that's okay. I mean, these are on the list here, so I guess I'll just read it. So I guess this is for Nachum, which is if RFA is combined with doxorubicin, when should you inject it and what dose? And is it necessary to involve a medical oncologist?
Okay, so that's a compound question, but thanks for asking it. In all due respect, I think that the best way that we're going to practice interventional oncology is in a multidisciplinary setting, in which case there should always be a medical oncologist, radiation therapist, and surgeon involved, at least in some of the decision-making of what's best for the patient. The question as to whether or not a medical oncologist versus an interventional oncologist is actually writing the prescription is actually going to be dependent upon local practices, and we have people ranging from spanning the globe in terms of time zones and countries here. So that's I'm originally from Massachusetts. All politics is local, so that I can't give a definitive answer on that. In regard to when to give the doxorubicin, it depends on how the doxorubicin is being given. If the doxorubicin is being given as part of the chemoembolization mixture, we would advocate, based upon our research, to do the TACE first and then do the RF ablation. We tend, in the liposomal doxorubicin studies, we gave the doxorubicin after the RF ablation, at least an hour after, because we didn't want the liposomes to be destroyed. We wanted them to stay around for longer circulation. Undoubtedly, if one is giving chemotherapeutics without liposomes and the like, the closer to the time of the ablation is probably the best to make sure that you get the best synergy.
Okay, thank you. Thank you so much. Madoff, how about the time is, no, it's time is coming. So how about Yang Kui? You have any questions?
Yeah, I have a question for David New. Do you have any experience on CRCLM if the lesions in bilobal liver very extensive liver metathesis? Do you have experience to use Y-line to control these lesions?
Yes. So in the setting of multicentric metastatic colorectal carcinoma, that patients have received basically their maximum chemotherapy, as well as all ablation and surgical strategies excluded, we have had experience with use of SIRT therapy. However, I think when we go back to the mechanisms of action of this type of therapy, as well as embolization therapy in general, we know that many of these tumors that have been treated for so long have become scars with a small amount of viable tumor rather than hypervascular tumors with very clear vascular targets. So in the setting of colorectal carcinoma, although the literature has suggested that there is an improvement in time to progression and a suggestion of improvement in survival, we only select for patients that have demonstrated on multiphasic imaging hypervascularity. So in other words, if we see a PET scan with increased metabolic activity that we think could be a good candidate for SIRT, we will get an MRI or a CT in multiple phases to be able to look at the vascularity of the tumors. And if we feel that the vascularity allows us to deposit enough radiation into the tumor without causing damage to the liver, we will proceed. To be completely honest with you, Professor Gu, that the number of patients that are like this that get referred to our clinic are very small because many of these patients have received chemotherapy for several years. And whether we do Dabiri, whether we do CTACE with irinotecan or SIRT therapy, we know that the treatment is not getting into the tumor, so we're not really making a big difference.
Okay, thank you very much. So because the time is over, so now thank you for every speakers and from the United States, from the Israel, from Canada, from China. So the online classroom, I think is very, very interesting because we hope we'll continue to organize online classroom and online study and during a special time. Okay, so Mado, say
No, thanks. I just want thanks. I think it was a great I think it was a great session. I'm glad to be a part of it and co-moderate this with you. I think the topics were very pertinent and timely, and really want to thank all the speakers, CCMA, ECHO, and SIO for this opportunity. And I really think that we're going to continue this. And with that, I think that we should probably wrap this up. So thanks everybody for your participation.
Thank you, professors. Thank you very much. We appreciate all your efforts and excellent work today. And audience, please don't forget to subscribe to our Echo Microwave LinkedIn account to get the future information about the webinars. And if you have any questions, you still can send us email to the account you see in chat box. So thank you very much, everyone. Thank you.
Thank you.
Thanks.
Bye-bye.
Thank you.
Have a good day.
Bye-bye. Okay. David Liu, bye-bye.
Thank you. Bye-bye.
Bye.
Thank you. Nothing is